Good evening, everyone. Welcome to tonight's webinar. My name is Dan Green. I'll be your host this evening. Thanks for joining. So tonight is a Sunday night. It is October 30th, 2022. And as it is a Sunday night, we will be doing cases from folks' case lists. So I will ask for volunteers in just a second. I will ask if you've been in the hot seat, let's say last Wednesday or Tuesday or Wednesday of last week, that you not volunteer at first so that we can give other folks an opportunity to experience the hot seat, if you will. Okay, having said that, let's get started. By the way, we will be going till 10 o'clock tonight. Consequently, I will pause probably around 9:20-ish to go over questions, and then again at 9:50 to go over questions. So please put them in the box, or you can raise your hand at that time, and be happy to try to answer them. All right, let's see. Alexandra, see your hand up.
Hi.
How are you?
I'm good. How are you?
I'm doing well, thank you. Are you a generalist or a specialist?
I'm an REI fellow.
An REI fellow. Okay. Did you send your lists in?
Yeah, it should be in October. And I've done a lot of OB practice, so could we do either GYN or office?
We can. Just looking for your list. Okay. Looks like we have it here. Okay. Give me 1 second here.
Sure.
You have just a little bit of infertility on your list.
It's like all infertility. I know.
Okay. Let's show your list in just a second. All right, so patient number 69 had a submucosal myoma and infertility, hysteroscopic myomectomy in the past. Let's say that fertility was not a concern for her. Was she having any other symptoms from this myoma?
No. Previously, she had a history of abnormal uterine bleeding and had a hysteroscopic resection a few years in the past. But at present, infertility was her only symptom as related to her fibroid.
Okay, so let's say that she had abnormal uterine bleeding again.
Mm-hmm.
Let's say that she wanted definitive treatment. How would you decide what type of hysterectomy you would perform on her if that's what she opted for?
I would take a thorough history. So I would look at her medical comorbidity, surgical history, see if she's had any abdominal pelvic surgery or that there's any question for possible adhesions or scar tissue. I would see if there's any concern for any adnexal pathology that would require maybe looking for from above, evaluate her OB history and her parity to see if she has had any vaginal delivery. And then on physical exam, I would evaluate for the size of her uterus, so mobility, the descensus, and in general, I would prefer to do the most minimally invasive route as possible, so transvaginal, as long as I can safely remove the uterus.
Okay. And what if she said to you, hey doc, I want a hysterectomy, but I want to keep my cervix because I think it plays a role in my sexual function and response. How would you counsel her?
I would counsel her that, there's no evidence to show that retaining the cervix contributes to sexual function, nor does it really change vaginal length if the vaginal cuff is suspended adequately, and that she would also need continuous cervical cancer screening, which is also one of the downsides of doing a supracervical hysterectomy in a patient like this. And I'd also counsel her that there is a risk of intermittent bleeding afterwards if there's some endometrial tissue that's left behind in that cervical stump.
Okay. So cervical cancer screening, she could have bleeding, and there's no improvement in function, sexual function, right?
Yeah.
Okay. What about pelvic support? Does leaving the cervix help with pelvic support?
Not necessarily. If you were to remove the cervix, you could always incorporate your apices of your cuff to the uterosacrals and suspend the cuff that way. And so, yes, you'd be removing level 1 support in the cardinals and the uterosacrals, but you would still be able to give adequate support of the cuff without the cervix.
So is there any benefit at all to supracervical hysterectomy?
I think in a patient that there's distorted anatomy, they have a history of like multiple resections and you can't safely dissect the cervix away, or if someone was seeing a pelvic floor surgeon for a concomitant urogyne procedure like an abdominal sacrocolpopexy, I do know that some urogynecologists prefer to do it with the cervix in situ, but not that I'm aware of.
Okay. Give me 1 second. All right. One more minute. Okay. So no benefit to pelvic support and no overall benefits, again, except for the distorted anatomy of the sacrocolpopexy.
Yeah.
Okay. I really don't have a lot else to ask you. Well, I'll ask you one more, even though I think we did this one last time. But if you do an opportunistic salpingectomy, how much would you reduce her future risk of ovarian or peritoneal cancer? I think we did this one on Wednesday, but hopefully you were listening.
Yeah, I think it's 40 to 60% is what you guys said.
Yeah, it was 65% was someone put in the chat box for us. But yeah, the numbers that I'm most familiar with are the 40 to 60, but I think ACOG is actually saying 65. So very good. I actually have very few comments. I think you did a great job. So if the patient had a supracervical hysterectomy, the only thing, and it's not been, is a slightly shorter operating time. We would think that there should be fewer injuries, but that's not been shown to be the case. And we think that I would intuitively think there'd be less blood loss because you've taken less bites, so to speak. But that's not been shown to be the case either. You mentioned distorted anatomy, so if someone has a lot of scar tissue and they've had normal PAPs, obviously you could consider leaving the cervix in that case. Obviously, the other situation would be somebody who's having emergent surgery or is unstable, like in a cesarean hysterectomy potentially.
Right, okay.
One other downside, you mentioned, need for cervical cancer screening. They could have bleeding in the future. The other possibility, obviously, if they have cervical cancer screening and it comes back positive, is they could need subsequent surgery, either in the form of a LEEP or cone, or even up to and including a full trachelectomy. Excuse me.
Okay.
I thought you did a great job, though. Otherwise, thank you for volunteering.
Thank you.
Sure. Okay, so let's see. Brittany, looks like you're self-muted.
Can you hear me okay?
Yes, I can hear you now. Thank you.
Great, thank you.
Are you a generalist?
Yes, sir, I'm a generalist.
Specialist? Okay.
A generalist.
Gotcha. Thank you. Okay, so in a second you should see your list, whether you want to or not. Yeah, won't you be happy when you don't have to look at this again?
Yes, sir, I will be quite relieved.
Okay. Were you on Wednesday?
No, I was not.
Okay. Then we won't ask you if we covered something. I can't remember whether we did. I think we did cerclage, but I got to tell you, I've done so many of these in the past week. They're all running together. Okay. Patient number 13 is a 26-year-old at 38 and 1 who's GBS positive, had precipitous labor. She was not given antibiotics, and she had a vaginal delivery. So how come, I get the precipitous labor, but what did you think the time course was between like when she presented with the GBS history and when she ultimately delivered?
Yeah, so this patient did not make it outside of our OB triage room before she precipitously delivered. So she was probably from door to delivery 30 minutes.
Okay, what's the minimum time obviously the longer the time, the better. But what do you shoot for in terms of minimum time to have antibiotics on board for their thought to be a possible benefit?
Yes, sir. So our goal is 4 hours of IV antibiotics truly before the water is broken, but certainly before delivery.
Okay, and what antibiotics would you typically use for a patient who's GBS positive?
So at my hospital, we use ampicillin, 2 grams as a loading dose, and then 1 gram Q4 after that. I know that penicillin is used at many hospitals, but our protocol is ampicillin.
Okay. What gestational age do you do your GBS cultures?
Routinely 36 weeks. If I'm at all concerned that a patient is at risk of delivering prior to 39 weeks, and I would try to do a culture within 4 weeks of the time of delivery, the anticipated time of delivery.
So are you saying that GBS cultures are only valid for 4 weeks?
They are most reliable within 4 weeks, such that if I had swabbed a patient at 28 weeks and then 36 weeks came along and they were still pregnant, I would repeat the culture if it had been negative. If it was positive in the past, I would not repeat it, and I would treat them as if they were GBS positive.
So let's say you do a culture. I'm sorry. So if I heard you correctly, you said you normally would do your cultures at 36 weeks. Is that correct?
Yes. Yes, correct.
Okay. So let's say you did a culture at 36 weeks and the patient now reaches her due date of 40 weeks, but has not gone into labor yet. Do you repeat the culture?
I do not repeat the culture. I would repeat the culture if they were past 41 weeks, although that would be a tricky situation since the culture takes 4 to 5 days, but I would not repeat it at 40 weeks.
Well, so what would you do if the patient came in at, let's say, 40 and 4 days in labor?
If they did not have any risk factors to have a baby with GBS sepsis and they had been negative in the past, I would not treat them.
Well, would you treat them as GBS unknown?
Well, I think that if they were ruptured for greater than 18 hours, I would have to look that up.
Okay. So let's go back to the GBS culture. Let's say you do have somebody who you're doing a culture on at 36 weeks, and she is found to be GBS positive, but she reports to you a history of being penicillin allergic. How would you manage that patient?
I would request sensitivities from our lab on the culture.
Okay. Any particular drugs you're looking to see if it's sensitive to?
Clindamycin specifically.
Okay, and if it is, you treat her with Clinda, I assume?
I would.
Okay, what if it's resistant to clindamycin?
If she had a severe penicillin allergy and it was resistant to clindamycin, I would treat with vancomycin.
Okay. What are your criteria when you have a patient who is GBS unknown? What are your criteria for recommending treatment?
If the patient is a GBS unknown and less than 37 weeks, I would treat regardless. If they are over 37 weeks and GBS unknown, I would ask them if they had had a history of a child with GBS sepsis, if they had been GBS positive in another pregnancy, if their water had been broken for greater than 18 hours in GBS unknown. That would be my criteria for treatment.
Okay. And what would you treat a patient who's GBS unknown, who's allergic?
I would treat them with, depending on the severe, so if they had a severe penicillin allergy, I would treat them with vancomycin.
All right. So let's see. Cephalosporin, you said, and vancomycin there. I'm just looking to see if there's anything else that we want to ask. I think that's it. Okay, thank you. So let's go over it.
Thank you.
Sure, my pleasure. So let's see. So we want to have antibiotics on board. Obviously, the longer the better. So, certainly 4 hours, but I believe the benefit even may take place as long as they have 2 hours between the administration and delivery. I will say I'm going back a little bit of time to remember that, but that is my recollection. A GBS culture is thought to be valid for 5 weeks. Hence the recommendation update a year or two ago to consider, we used to do them 35 to 36 weeks, as you remember, and now they're recommending them more toward 36 to 37. So most folks are doing them at 36 because they're delivering their patients typically by 41 weeks. Excuse me.
Bless you.
Thank you. They're delivering usually by 41 weeks, so it still covers the valid period at that time. I'm sorry. So the patient that's 40 in 4 days really should be, if you did it at 36 weeks, she should be covered, assuming it was negative. You mentioned if somebody is penicillin allergic, you'd send for sensitivities, particularly looking for clindamycin. Certainly that's appropriate. As you know, it used to be erythro and clindamycin. Many hospitals or labs are still checking anyway, doing the dual sensitivity because of the concern for inducible resistance. But Clinda is what is called out in the bulletin, if you will. And then if they're resistant to Clinda, then they would be a candidate for Vanco. But as you pointed out, you want to assess the severity of the penicillin allergy. If it's not a severe allergy, such as anaphylaxis or what have you, you could get away with a cephalosporin. There's some folks even go to the point of actually sending the patient to an allergist to be tested for penicillin allergy, because as you well know, patients over-report penicillin allergies, or at least if they are allergic, to find out the severity of the allergy. Now, GBS unknown, less than 37 weeks, as you said, GBS positive or prior septic infant. So yeah, if they've been GBS positive in a prior pregnancy, that is the new criteria that they've added. that person would be a candidate for treatment. You said ruptured membranes greater than 18 hours. That's good. A couple other, or two others. One of these is implied. If the patient has a history of GBS bacteria, obviously she'd be a candidate. And then if a patient has a fever of over 100.4, she would also, with GBS unknown, she would also be a candidate for treatment.
Got it.
And then you said Vanco, again, depending on the severity of the allergy, so that was good. If it's a severe allergy, if not, as you mentioned, the cephalosporin would be appropriate. So any questions about this?
No, thank you so much. I got myself into a corner with the 4 versus 5 weeks. I won't forget now.
But you did very well otherwise. Thank you.
Okay, thanks.
Charlotte, trying to get you off mute next.
Hi, I'm here.
Hey, how you doing?
Good, how are you?
Good, thanks. Are you a generalist or specialist?
Generalist.
Okay. So let's see here. So patient number 3 on your office list is 53, and she had dyspareunia, and she has difficulty using vaginal dilators. Was there something that precipitated her vaginal narrowing, or was it just menopause?
I believe it was just menopause.
Okay. Do you recall approximately how long she'd been menopausal?
I don't recall her having gone through early menopause, so I would say probably several years.
Okay. I mean, were you surprised at 53 that she would have this necessarily this vaginal narrowing if she went through menopause roughly around the normal age of menopause?
Yeah, I would say most women by that age would still have fairly normal vaginal width and maybe some dryness that would lead to dyspareunia, but not, I think for her, she was pretty much unable to have intercourse.
Okay. So now you prescribe vaginal estrogen. How did this patient still have her uterus?
She did.
Okay. And how often did you recommend the patient use the vaginal estrogen?
So I recommended that she apply it nightly for 2 weeks and then decrease to 2 nights per week.
Okay. Is it ever necessary to cycle a patient with progesterone if they have an intact uterus?
If you're using systemic estrogen, then yes, but for vaginal, it's thought to have very little systemic absorption.
Which vaginal estrogen preparation would have the least systemic absorption?
I believe Vagifem, the tablet form. But
Okay.
I'm not
Which
on
one? Okay, which one has the most systemic absorption?
I would think the cream.
Okay. And what about the ring?
I think that is intermediate, but I'm not sure.
All right. Okay. So when you have a patient that presents complaining of dyspareunia, let's say the patient was 42 and not menopausal. So what would be your differential for dyspareunia in a 42-year-old?
Sure. So that would include endometriosis. It could be something more psychological, like a history of sexual assault or abuse. It could be pelvic floor dysfunction, so like elevator spasm. She could have vaginismus or vulvodynia, or there could be a skin or vaginal infection, so a skin or mucosal infection like herpes if she were having frequent outbreaks, or a vaginitis like yeast or trichomonas could be causing those symptoms.
Okay. How would you make a diagnosis of vulvodynia?
So that is a diagnosis of exclusion. So we need to rule out structural abnormalities or infections or skin disorders that could be the cause. And then we should be able to reproduce some pain on exam, like with the Q-tip test.
Okay. So let's say you made the diagnosis. What would you recommend in terms of treatment?
So one treatment I would suggest would be lidocaine gel that could be applied before intercourse. I would recommend pelvic floor physical therapy. And then there are some topical or even systemic treatments, like I think amitriptyline is a topical treatment. I believe there's also topical gabapentin that can be used.
Okay. Anything else about vulvodynia?
So in severe cases where medical therapy has failed, you can do a vestibulectomy.
Would you do that?
I have never performed one myself, and I, would steer the patient towards trying many medical management options first.
Okay. All right. Very good. Let's go over it. So, Charlotte, one technique comment I would make: whenever you have a complex differential diagnosis, if I were you, I would try to think of it at the highest level possible. And by that, I mean, like, I would have started out saying, well, my differential for dyspareunia would include insertional etiologies versus deep penetration dyspareunia. And I'm not saying you have to say that by any stretch of the imagination, but it can help sometimes to, if we divide it up into segments or compartments, to make sure that we, manage or we mention, most of the different things that we would be considering. Like you said, endometriosis, and you said psychiatric. So I would agree with you. Endometriosis would definitely come to mind for deep penetration dyspareunia, but in that same vein, I would be thinking, okay, she could have fibroids, she could have adhesions, she could have persistent ovarian cyst. So these would be all, she could have GI or GU problem like interstitial cystitis, or some bowel issue that's seems to be aggravated, particularly during intercourse, for example. Again, a little bit less likely on the GI, but still in all, I think you get the idea of what I'm suggesting.
Yeah.
Chronic pelvic pain is the other scenario where the compartmentalizing it can help a little bit because it's such a broad differential. So you mentioned psychiatric. By all means, that certainly could be a cause. You mentioned pelvic floor spasm or tension, including the levator spasm, vaginismus, vulvodynia. Then I think your infections was good and important that you mentioned it. I mean, not just yeast and trich, but she could have gonorrhea, she could have chlamydia. Also, it could cause the problem. You said you were going to rule out structural or skin disorders. Again, things like lichen sclerosis, not often, but certainly could cause the problem. You mentioned the infections and included herpes. I thought that was good. You said, let's see, you said rule out structural. I'm not sure what you mean structural, other than potentially vaginal narrowing or change in the caliber of the vagina. Was there something else you were thinking of with structural?
I guess I was thinking of things like lichen sclerosis or other, I guess structural
Okay.
wasn't the best word for that.
Okay. All right. So then you said for vulvodynia, lidocaine jelly, certainly that would be something to consider. Other things that you could consider. I'm not saying this is wrong. I'm not familiar with topical gabapentin or amitriptyline, but I'm sure somebody on the call is probably familiar with that, assuming that's an acceptable treatment. So if you are, please feel free to get into that question or comment box. It's always appreciated. But amitriptyline certainly can be given orally. There's vaginal diazepam, but again, that's a little bit more, to my understanding, used for vaginismus than it is for vulvodynia. But sometimes people will try different hormone creams, like using estrogen cream as well. What else? Certainly gabapentin is something that could be tried. I'm just not sure about the topical aspect of it. The vestibulectomy would be a last resort. I asked you if you would do it, and you said you'd never done one before. I probably would answer that part of the question just a little differently. I would say that, if I really had exhausted all my medical management, I would refer the patient to a pelvic pain specialist, especially since you haven't done one before. And it's a shade on the controversial side. So, I don't think I would be volunteering that. I would be making the call on that, especially, again, having not done it.
Okay.
Any questions? But your Q-tip test, of course, for helping to diagnose it was appropriate.
No, I think that's good. Thanks.
Thank you. All right, let's see. So topical gabapentin and TCA can be used, but typically need compounding pharmacy. So that was a comment from the box. Thank you very much, Jordan. Appreciate it. Okay, we will take our next volunteer. Give me 1 second. Christine, looks like you're volunteering. Are you there, Christine?
Hi.
How are you?
Good. How are you?
Good, thanks. Are you a generalist or specialist?
I'm a specialist. I'm GYN oncology.
Okay, I'm going to do an office. I normally would be up for GYN, but I think I'll do an office with you if that's okay.
That's fine.
Okay. All right, let's see what we have here. Pardon me. All right, so patient number 10 is a 43-year-old G3P3 that had a right ovarian cyst, secondary infertility. She had a transvaginal ultrasound with a CA-125, pelvic exam. The ultrasound, apparently the uterus was 10 centimeters, did show a 2 centimeter simple cyst, and clearance for IVF from REI, and the CA-125 was 12.4. So why did this patient have a CA-125. Is that for this 2-centimeter cyst?
Yes, it was ordered when she was referred to me. She was sent so I could look at her ultrasound, take a look at the CA-125 and determine whether I was concerned that it was a malignant mass or not prior to her going through with IVF.
Was she sent by a primary care or GYN person, or?
It was sent from her reproductive endocrinologist.
Oh my God. Am I missing something here?
No, that was one of my consults.
No, I'm not being critical of you. It's a little bit of one of, you're too young to remember the movie The Exorcist, but my head's spinning around because it's just.
Well, he initially was sent to me for like I believe a 4-centimeter simple cyst on the right. And when I repeated her transvaginal ultrasound, there was a simple cyst on the left.
Wow, that's kind of scary. Okay. So if you were seeing this patient, in addition to the ovarian cyst, let's say you were going to do the workup for the patient for secondary infertility, how would you go about doing that?
So for a patient who presents with secondary infertility, I first would take a detailed history from the patient. I would find out if this is a same or new partner from her previous pregnancies, and if that partner was able to achieve a pregnancy. I would ask her about what her menstrual period was like, if she's had any changes from that. Based off of, and in this patient, her age was 43, I would determine what labs I would need to order. I would start with doing a transvaginal ultrasound to look for any structural abnormalities that I could see. If her periods were becoming more abnormal, I would consider ordering an FSH to see if she was in the menopausal phase. And I would start with a semen analysis on the male partner.
So you're going to get a semen analysis even if it's the same person that was responsible for her 3 other children?
If it was a new male partner.
For a new male partner. All right. So what are you looking for? You said structural. What are you looking for on the ultrasound specifically?
So on
a 2-centimeter. Sorry, I couldn't resist.
You know,
that was not critical.
Referred to GYN oncology sometimes. I would be looking to see if there were any, significant pelvic masses that may be suggestive of either, a malignancy or things like that. I would be looking to see if there was any new leiomyomas that could be contorting the cavity. I would be looking at the lining to see how thick the uterine lining was and if there's any suggestive of polyps or masses within the lining. And then based off
Do you
of
think that would cause do you think that would cause, you said polyps within the lining, do you think that would necessarily cause infertility?
Depending on how much it could be distorting the cavity, if it was a very large polyp or if there was hyperplasia seen, there might be a difficulty with achieving pregnancy.
Well, how are you going to tell if she's got hyperplasia at 43 based on an ultrasound?
Looking at the lining, I may recommend doing an endometrial biopsy or doing a hysteroscopy to take a better look in the cavity based off of the results from the ultrasound.
What would you see? What would cause you to do that based on an ultrasound?
If there was any suggestion of an intrauterine mass, if there's a thickened lining, I would do an endometrial biopsy prior to presenting to the operating room.
Well, what would be a thickened lining in a 43-year-old?
So because she'd still be premenopausal, if her periods were abnormal and it was, between 1 and 2 centimeters, I would consider taking a look at it with abnormal periods.
Well, you said you'd consider it. I mean, would you recommend a biopsy if she's got, let's say, a 15-millimeter lining and She's having, let's say, normal cycles, albeit they're heavy.
If she had no other risk factors, the new recommendation is not to biopsy, from my understanding, unless they're older than age 45. I would personally biopsy. I know I'm not supposed to say that on the test, but I tend to lean more towards biopsying because there are a lot of risk factors for endometrial cancer that most women meet criteria for, such as obesity. And this woman, if I do remember correctly, her BMI was greater than 30.
Well, so would you be concerned with somebody who's got a lining, let's say, again, of 15 millimeters, but is not having oligomenorrhea, even if she's obese?
No, if she wasn't having any issues with her menses, I would not.
Well, again, let's say her periods are heavy, but they're monthly.
I would err on the side of caution and perform an endometrial biopsy.
Okay. So back to our patient, you told me semen analysis if she had a new male partner. You were going to get an ultrasound looking potentially for polyps. You mentioned hyperplasia. We talked about the endometrial biopsy. Are there any other tests you would get for this patient?
I would order an AMH, but I would only do that prior to referring to a reproductive endocrinologist.
Okay. Even if she's got regular cycles?
Yes, prior to referral, because I wouldn't act off of that. I would only do that prior to referring to her.
So what if it's normal?
I would still order it prior to referral.
Well, yeah, you wouldn't know unless you ordered it, but I mean, so if you referred them, you wouldn't be referring her, obviously, for the AMH that's normal. Is that right?
I still would be referring her if it was a normal AMH.
Again, you mentioned AMH, transvaginal ultrasound, and possible semen analysis. Any other tests?
Other things that I would consider would be something that's tubal in nature.
I don't want to know what you consider. I want to know what you'd order.
I would order
No offense, but they're going to be picturing the patients right in front of you, you know, in your office. So they're going to want to know what you're going to do.
I would do an HSG to evaluate the tubal patency, as well as get another look at the inside lining of the uterus.
Okay. Anything else?
I would order during her cycles, I would order a day 3 FSH, and I would order a day 21 progesterone level to see what her natural cycle does, to see if she's ovulated.
What's the day 3 FSH going to tell you?
Oh, I'm going to have to relook that up.
Okay. Last question. You mentioned possibly doing an endometrial biopsy if the patient were on the heavy side and, you know, had a lining, let's say, between 1 and 2 centimeters. So if you were to do the biopsy, would there be any particular time of her cycle that might be extra useful or be helpful as far as the fertility goes?
I believe if I do the biopsy, I want to say around day 21, I can check and see if there's any deciddualization, but I, again, would have to look up the exact timing to perform that for fertility.
Okay. All right. Very good. Thank you. I'm actually going to see if we can get one of your colleagues on as well. Elizabeth, trying to unmute you.
Hi there.
There you go. Hi. Anything you want to add to or change from what Christine said?
I would say that as far as the 21-day progesterone, another option would be to have her do home LH kits to determine if she's ovulating.
Okay.
That would be
any comments on the, sorry, any comments on the day 3 FSH?
Actually, I wasn't clear as to what that was for either.
I remember ordering that in residency, but to be honest, I can't remember why we ordered it. That was a while ago.
Anything? So let's not get started as to who's been in residency longer than the other. Sorry. Any other comments or things you would do differently or agree with?
I guess, and I apologize. I've been listening, but my cat just ran out into the garage, so I had to walk away for a second, and I apologize. But I would say if she hasn't ordered it, you could consider to do ovarian reserve, to order either an AMH or to do a transvaginal ultrasound to look at an antral follicle count.
Okay.
My question is, I was heard on previous ones not to say to order an AMH because you're not going to do anything with it, or should we be saying that we would order it? Because I know personally I wouldn't know how to, I guess, what I would do the next steps based off of that.
Yeah, so I would suggest probably not ordering it if the patient's having normal cycles. So when I say normal cycles, I mean if she's having heavy bleeding, whatever, that would be included in the quote unquote normal cycles. If the patient tells you, hey, I'm only having 2 or 3 periods a year, then we'd be starting to get concerned. She could have oligomenorrhea. You mentioned she might be heavy, so that could be one of the explanations. But it also could be that she's, starting to head toward perimenopause. So in a situation like that, it's going to give you some more information. But as you also pointed out, you're still going to send her to the REI. So not the end of the world if you wait, if you wait for the REI to send it. I mean, personally, the plus side to doing it is it's one less thing that the REI necessarily has to order to give the patient more information sooner. On the other hand, if you order it and it's abnormal, then you're going to have to be the one kind of trying to explain it to her, where you may not have the expertise to be able to say, okay, you can tell her what it means, but clinically what the implication is and how that's going to affect her fertility, she's going to have those questions, and that may be beyond your level of expertise. I know it would be beyond mine.
Oh, it
so,
would be.
Yeah. So you can make a case for ordering it or not ordering it. But again, if the patient's having, monthly cycles and not, it's one thing if she misses 1 period a year or something like that. I definitely wouldn't order it. I'd let the REI order it if they thought it were appropriate. Especially if you're going to do the day 3 FSH. I mean, my understanding of that is it's a proxy for ovarian reserve. It's not obviously anywhere. It's not as good as an AMH, but a normal value at that point would be more consistent with a normal normal ovarian reserve. But again, I think we have REIs on the phone, so by all means. In fact, we may have to get Christine back on to fully explain that. Oh, I'm sorry. I meant to say Charlotte. Excuse me. Sorry about that. It's all these C letters that are messing me up. Charlotte, any opinion about whether you want the AMA? I'm trying to get you off mute. Let me try again. Okay.
I'm a generalist. I think Allie was the REI fellow.
Oh my gosh. A memory is a terrible thing to waste. been a long day, folks. Sorry, I had to officiate a wedding yesterday. Well, thank you. So, Alex, are you trying to get you off mute?
Hi, sorry, is the questions about FSH?
Yes. Well, no. The question's actually about AMH. Would you prefer an AMH be ordered prior to someone sending you the patient at, let's say, in their 40s?
I mean, in their 40s, most likely it's just normal age-related fertility decline. We will get an AMH on anyone with a vagina, basically. So
I
it's
do the
helpful,
same with biopsies.
but I mean, I think like the textbook answer is that it doesn't predict someone's ability to get pregnant naturally. It does help to come with information, but we order 1 million lots anyways. So I would say like for purposes of this, just like FSH, LH, and E2 are, and a luteal progesterone are like the most useful things. And then sonohistogram to look at the cavity, hysterosalpingogram to look at the tubes, and then a semen analysis, even if it's the same partner, because people get COVID and their sperm count drops, or they get sick or use testosterone, or things happen. So sperm that was good a few years ago isn't always good now.
Great, thank you. So certainly don't want to disagree with my consultants in any way, but the one comment I don't, I mean, well, I'm going to throw it back at you, actually. Do you mind if I call you Alex? Oh, she went back on mute.
Sorry, that's fine.
Sorry. So, you know, are the if a patient is having normal cycles, is the FSH and LH and estradiol, are they, I mean, I wouldn't think to order those, to be honest with you. I mean, the day 21 progesterone to confirm ovulation seems appropriate, but I'm not sure I would do those other blood tests, but you're the expert.
I would, because you know, as you get closer to menopause, a lot of times your cycles are shorter. So now instead of having like a 28-day cycle, you could start having 20, 21-day cycles. So I think if your FSH is 20 and you're still having periods, but they're closer together or heavier in nature, that could be an indication that you have diminished ovarian reserve, especially if your estrogen is very low.
Okay, so even if she's having normal monthly cycles?
I would, yeah.
Okay. So taught me something new. I would not have thought that. But I would definitely agree with the day 21 progesterone. The AMH, it sounds like it's plus minus. It sounds like Alex, they're going to get them anyway. The other comments that were made, so home LH kits, thank you, Elizabeth, certainly a good suggestion. I think so for the endometrial biopsy, at least for board purposes, you know, if somebody's got a lining of 1 to 2 centimeters, that's not necessarily abnormal in a non-menopausal patient. So if she's got normal cycles, I wouldn't be biopsying her just for that. If her periods were a little bit on the heavy side, but they've been heavy for some time, again, I wouldn't necessarily biopsy her. If she's telling me she's got oligomenorrhea, that's a whole different story. You know, then I would be more concerned. So be careful. I know a lot of your pathologists are radiologists are reporting quote unquote thickened endometrium in your non-menopausal patients. There really is no such thing. Really what we're looking for is heterogeneity. So it's different if you were to see heterogeneous lining, and I think this is kind of what Christine was talking about in terms of polyps and whatever. In that situation, different story. You could either biopsy her, or you could consider a DNC hysteroscopy if you're really thinking that the patient might have a polyp. Not only for the fertility aspect of it, but just if she's having even heavy periods, even if they're regular, that may help to make her menses more normal in terms of volume. What was the other thing? The HSG, definitely think that's a good test to get. I think we all agree. We certainly want to check tubal patency. You will get some hint of intracavitary filling, obviously with the HSG. The other thing, the one thing I was alluding to when I asked Christine about the timing, if we were going to do, I don't want to say a questionable endometrial biopsy, but if we were going to do an endometrial biopsy because we were, let's say the tissue was heterogeneous, whatever, you could consider doing it around day 25 or 26 of a 28-day cycle. You know, the endometrial biopsies long ago used to be part of the workup for infertility to try to diagnose a luteal phase defect. We were trying to see if the uterine lining was responding appropriately to where the patient should be in her cycle. And if it were a mismatch of more than 1 to 2 days, we said that they had a luteal phase defect, or at least we're suspicious for it, and we would consider early vaginal progesterone early, you know, in pregnancy to help support the pregnancy. So I know that's fallen out of favor, and by no means, you know, would you just go do an endometrial biopsy to confirm that. But if you were going to do an endometrial biopsy for consideration of looking for a polyp perhaps, or if there was some other compelling reason to do it for the hyperplasia, if you could time it to then, you may get a little bit of extra information. But that's just kind of an aside. So I think that's it, unless any of our volunteers have any other comments on this one.
Can
Christine,
I make a comment about the
Alex?
here? Yeah. So yeah, with the polyps, generally speaking, what we tell people is that polyps are not the cause of infertility, but they are present in like 6 to 8% of people that have infertility. And so usually it's not the sole factor, but a contributing factor because of the inflammation. And then obviously it's a space occupying lesion. But in general, it's not like the cause of infertility.
Thank you. Yeah, I would, again, even with my generalist knowledge, would think of them more along the lines of, you know, patients, and again, probably not too, but recurrent miscarriage I would think there might be more of an issue there. But to be honest with you, I was thinking more along the lines of if we have a heterogeneous endometrium and or the patient's having heavy bleeding, as opposed to the thickened endometrium that was previously mentioned. But thank you for adding that in. Appreciate it. Christine, anything before we go back on mute? Questions, comments? Great. Well, thank you to all our experts and our volunteer for weighing in. Definitely appreciate that. We are at 9:30, so I am going to start with the questions and comments right now. So thanks for sending them in, folks. Let's see what we got. Okay. Systemic absorption of vaginal estrogen. Thank you for reminding me about that. This question is not just one of these, you know, hypotheticals like, you know, hey, you should memorize this because it has no clinical relevance, but, you know, they could ask you about it. This actually has clinical relevance. The most absorbed vaginal estrogen would be your estrogen cream, followed by the estrogen tablet, and the least absorption would be the estring. And the reason that this can be important is if you have a patient that has breast cancer that's having, you know, quality of life issues with respect to the hypoestrogenic state in the vagina, if you're going to put her on any kind of localized estrogen, you would want to obviously use the one with the least systemic absorption, and that would be the ring followed by the tablet. So those would be the best to use. In terms of cycling a patient on continuous estrogen, vaginally with an intact uterus, you really, as the person who answered that question, you really don't have to cycle the patient. But there was some talk and thought that if you were going to have the patient on vaginal estrogen nightly for in excess of 3 weeks, that it would be warranted to cycle the patient. So I would certainly say that if the patient is using it nightly for a month or more, that it would be reasonable. Again, there's no recommendations one way or another that I'm aware of, but it would be reasonable to cycle the patient at least once to see if she had a withdrawal bleed. If she did, obviously there's enough stimulation of the endometrial lining and you'll be glad that you cycled her. Again, most people do not use estrogen cream nightly for anything more than or at the most 3 weeks before they would switch to twice a week or 3 times a week. So uncommon scenario, but if you were using it for some reason every night, or your patient obviously, would be something to consider. And again, that's one of those questions that doesn't absolutely have a black and white answer, and so the board can see how you think and how you can process your knowledge of pharmacology, physiology, etc., and come up with a reasonable choice or option for your patient. So it's kind of one of those, let's think about it, and can you put together something that makes sense, especially in the absence of a recommendation. So thanks for the question and the reminder. There are compounding pharmacies that make amitriptyline and gabapentin topical formulations. Thanks very much, Lindsay. Appreciate that. Okay, can we review which have the highest systemic absorption? We just did that. Thanks for the question, though. I would order the AMH to gauge how well she would respond to IVF therapy. So that was another opinion that someone wrote in. And again, I think that's probably subject to debate within the REI folks. Obviously, if the patient's not having regular cycles, and 43, it would be on the early side of menopause, but it would not certainly be ovarian insufficiency by definition anyway. I think I'd leave that honestly up to the REI folks. But again, if you order it and send them, I think as Alex said, that's not bad, or they're going to order it. So I don't think there's a right or wrong absolutely as far as that goes. You can order the AMH as part of the REI workup. Oh, can you order the AMH as part of the REI workup? Well, again, I think Alex told us soon, it's one of the things that they're going to do as soon as the patient comes in, or at least at the first visit would be to send her for an AMH. So again, if you want to say that you're going to get it, that's fine. If you want to say during the test, if the question comes up, I'm not going to get an AMH, but I'm sure the REI would when they see the patient, then the next question could be, well, if you're sure they're going to get it, why couldn't you get it? And it would be reasonable. My only concern is I wouldn't want to have the discussion that I would want the REI to have in terms of the interpretation of the AMH if it were to come back abnormal. I'd rather the REI be able to review, options for the patient and likelihoods, because I just wouldn't be familiar with those numbers. All right. Alex, you. Thank you again for letting us call back on you. Appreciate it. REI referrals tend to take a long time, and they order another AMH again, so it's nice to see how it changes. I could be wrong. Alex, I'm not sure if you have any thoughts about that. Go ahead.
No, that's reasonable. I mean, they do change. Also, people on OCPs tend to have recovery of AMH after 90 days after like the life cycle of the antral follicle all the way through.
How much? I mean, do they change much over a relatively short time, a month or two?
I mean, it's all relative. If a patient has like diminished ovarian reserve and they're like declining rapidly, yes, but there's not like one specific rate that we quote. It's just patient to patient. But like someone on OCPs, if they had one done and it was really low, oftentimes we will repeat it like 3 months later. And then same with someone who's gotten chemo. Sometimes it can be really low right after chemo, but then 24 months later, it can show a little bit of improvement.
So that kind of makes sense because there's an outside, I don't want to say insult, but reason, that the patient her AMH may be altered. I guess what I'm thinking is, somebody who doesn't seem to be perimenopausal, let's say late 30s, but, having monthly cycles or maybe even this patient having monthly cycles, no vasomotor symptoms leading up to potentially for menopause. I mean, would you expect to see much of a change in her for, let's say, over 3 months?
Probably not, no.
Okay. So again, you're thinking patients that have some reason that would be more either perimenopausal or, birth control pills or some other insult, some other medication that might alter, like chemotherapy, as you said. Okay,
Right.
that kind of makes, thank you. It pacified my simple mind. I feel better now. Appreciate all your input. Thank you so much.
No worries.
Okay. I think that's it for the questions at this point. Emily, trying to get you off mute.
Hi, how's it going?
Hi, how are you?
Not too bad, how are you?
I'm getting an REI education tonight, so it's all good.
Ew. Like,
Let's
happy
see.
to not do that.
I'm sorry?
I said I'm happy to not take an REI question, preferably.
One of my best friends from training is an REI, so when I'm not teasing him about how much money he's making, any questions I used to have, I'm like, Larry, you owe me. You kept me. He was my junior resident. He kept me up all night. It was horrible. His internship was worse than mine, at least for me as his backup. Okay, so you're a generalist?
I am, yeah.
Okay. So patient number 3 is a 29-year-old G3P2 at 37 weeks at gestational hypertension and hypothyroidism.
Mm-hmm.
So what happens to the thyroid requirement in pregnancy?
So the thyroid requirement generally goes up during the pregnancy.
Okay, and what thyroid tests would you have TSH and free T4 each trimester?
Mm-hmm.
Would you ever do the TSH and free T4 any sooner than every 12 weeks?
I would, if I'm making changes in dosing, then I would do it every 4 to 6 weeks until normal and then space it back out to each trimester.
Okay, what are complications of severe, poorly controlled hypothyroidism in pregnancy?
So fetally, there can be fetal growth restriction. There can be abnormalities in neurologic development. I think it's creitism is the condition that fetuses can have. Those would be kind of the 2 main ones, and then I guess preterm delivery.
Okay, give me 1 second. Okay, so let's see, hypertensive management, induction of labor. So what about hyperthyroidism? How would you treat a patient with hyperthyroidism in pregnancy?
For a patient with hyperthyroidism, I would treat her with PTU in the first trimester and then methimazole in the second and third trimester.
Why are you going to switch?
PTU can cause liver injury, but methimazole can be teratogenic. So I would use PTU during the first trimester when fetal development is occurring, and then switch to methimazole after for maternal benefit.
So what are the potential embryopathy complications associated with methimazole?
I believe it's something with the development of the limbs and bones, but I would have to look that up.
Okay. Let's say you had a patient that came in thyroid storm. How would you manage that patient?
Yeah, I would bring in consultants, including maternal fetal medicine and the ICU. I would give her a loading dose of PTU. I believe it's a gram. She would get IV steroids, and then symptom management. These patients typically have tachycardia, which I would treat with a beta blocker, and then very close monitoring in an ICU.
Okay.
Oh, and sorry, you need iodine as well. So you could do 10, I would do 10 drops of glucose iodine.
Okay. So you mentioned IV steroids. Can you be more specific and what the purpose of that is?
It would be,
You don't need to get the dose, but I'm just,
say
why
that
are you
again?
giving them, I guess? But you don't need to give me the dose, but why are
Okay.
you giving the steroids?
With, I can't remember.
Okay.
It's not for maternal benefit. This isn't for fetal lung maturity, but
I'm sorry, you would or wouldn't be giving it for fetal lung maturity?
this would not be. This would be for, it's a maternal indication.
Okay. For maternal indication. Okay. All right, very good. Let's go over this one. So everything you said about the requirements in the first in pregnancy, you are going to have an increase in thyroid requirement in pregnancy. Your intervals were fine. If you have a hyperthyroid patient, though, you would want to be checking levels more toward the every 4 weeks for hyperthyroid, because obviously we don't want somebody coming in thyroid storm.
Makes sense.
So the hypothyroid, you said growth restriction, neurologic development. So again, creitism, which you said, preterm delivery. They're also at increased risk for miscarriage. Remember, it's one of the blood tests we get for recurrent miscarriage.
Yep.
So that would be the other thing I could think of.
Okay.
And there may be some others. I'm sure folks will write into the question box and let us know if they think of other things. In terms of hyperthyroidism, so PTU, you're right, there's thought to be liver toxicity. Recently, they've come out saying you can probably use PTU throughout all 3 trimesters. The risk of liver injury, they think, was overestimated. So you can conceivably use PTU, again, for the whole pregnancy. For what it's worth, not that this is any great deal, but we used to use PTU all the time for the whole pregnancy.
Yeah.
The concern about methimazole is that it's twofold. One is aplasia cutis, which is an incomplete closure of the skin usually on the scalp.
Okay.
And then the other thing is choanal atresia is the other concern with methimazole. So, yeah. Anyway, not saying it's wrong to change to methimazole, but it seems like, again, there seems to be gathering information that it's probably okay to stay with the PTU.
Yeah.
In terms of thyroid storm, good job with of course, mentioning that you're going to bring in your consultants, meaning MFM as well as ICU consultants. So again, guys, and I'm going to repeat this just because I'm sure most of you have heard me say this or heard someone say this in the past, but just in case, when you go to take the test, from being on these webinars or coming to a course or what have you, many of you, would almost skip the consultation because you're like, well, they're just going to say they're, on top of Mount Everest, taking pictures, celebrating their climb or something obscure like that. There's no urologist in the middle of Chicago for the whole, within 100-mile radius, that the examiner's going to say that. The reality is, they may say that, and they may ask, well, what's your consultant going to do? That's all, a possible scenario. However, having said that, you still should indicate where it's appropriate that you're going to bring in a consultant. If you don't say, hey, I'm going to consult, in this case, let's say MFM and the ICU doc, or MFM and endocrine or something like that, but a specialist who's better versed to handle this complication than we are as generalists, if you don't say that, they're going to think, okay, Dr. Jones, whoever the person I'm quizzing, I'm the examiner now. And I'm thinking, okay, this lady who I'm quizzing, is going to take care of it herself because she didn't say she's going to bring in a consultant. So please make sure that you say, again, as you did, Emily, please make sure where it's appropriate, you're going to bring in your consultant. Having said that, obviously we're not consulting somebody, an MFM, when our patient comes in without complications, but she comes in ruptured membranes at 36 and 6. We're going to deliver her. We don't need to call MFM for that. So just make sure it's an appropriate, referral, and do mention it again, even at the risk that they say, well, they're out of town, or what are they going to do?
Right.
Very good. Any questions?
What was the the steroid. Is it a sympathetic really? I was like, I know I can see it in the table, and then I just blank.
Thanks for, what's wrong with me tonight? Yeah, so PTU would be something, I'll get to the steroid in a second. So PTU, iodine, your 10 drops of Lugol's was good. Beta blocker, usually for the tachycardia, and the steroids to prevent the peripheral conversion of T4 to T3.
That's it. Okay. I was like, I know it's
So
for something related, but I can't remember what. Okay. Peripheral conversion of T4 to T3.
Yep. All right.
All right. Thank you.
Very good. Thank you. Okay. So let's see if we can sneak one more in. Emily, trying to take you off mute. There's your self mute. There you go.
Hi,
How are you?
I'm doing well. How are you?
I'm doing okay. Are you a generalist or specialist?
I'm a generalist.
Okay. Let's see what we can torment you about.
Great.
Let's see what we can ask you about. Okay, so patient number 10 on your GYN list is a 41-year-old G5P1 with abnormal bleeding. Biopsy was inconclusive for complex atypical hyperplasia. You did a hysteroscopy, polypectomy, DNC, and everything was benign. So what made the biopsy inconclusive? I mean, were there just too few cells that they couldn't tell? I mean,
Yes, sir. There was low cellularity on the endometrial sampling.
I mean, did they say that there was low sampling, but what we did see looked like there was atypical hyperplasia?
It was more of the verbiage of cannot rule out atypical hyperplasia due to cellularity.
Okay, so after this DNC hysteroscopy polypectomy, what did you do with the patient?
So I brought her back in for her post-op visit and discussed with her the difference in pathology between the endometrial biopsy and then the hysteroscopy DNC. Discussed with her that having that separation or that difference in making sure we didn't have cancer and then having a larger sample saying everything was benign did leave me a little more concerned about any bleeding abnormalities that she might have in the future. And so the plan for her was to keep a very strict menstrual diary and then to also follow up in a year, or if she had any issues before then, to repeat sampling if need be.
Okay, let's say your biopsy had come back, not saying inconclusive, suspicious for, let's say it came back worded suspicious for complex atypical hyperplasia. You do your hysteroscopy DNC and it comes back benign. What would you recommend for that patient?
I would probably discuss with her the option of, this patient in particular has a BMI of about 41 and some other risk factors. She has type 2 diabetes that she manages with insulin. So for her, I would probably refer her to GYN oncology to decide if proceeding with a more strategic plan to follow her would be warranted, or if they thought just follow up with me would be fine. So I would offer her a referral to GYN oncology.
Okay, again, let's change it just one more time. So instead of the suspicious for complex atypical hyperplasia, let's say it came back showing atypical hyperplasia. So you did the hysteroscopy D&C, and the endometrium looks, you couldn't draw a more appropriate looking uniform endometrium. Plus minus on the polypectomy, we can leave it in, but everything you got on your D&C hysteroscopy is benign. So you have a discrepancy between your endometrial biopsy and your D&C hysteroscopy. What would you do?
So I would discuss with her the possibility that she had a very focal location of complex atypical hyperplasia that may have been acquired completely with the endometrial biopsy, despite that being a smaller sample. And I would also discuss with her the option of
what would you recommend?
I would like for this patient in particular to be on a progesterone therapy for protection of her endometrial lining, and also a discussion again with GYN oncology.
Okay.
So,
what would you personally recommend?
I would recommend
the progesterone, or would you recommend hysterectomy?
I would personally, for this patient, given I know her size and her medical comorbidities, if she wanted to avoid hysterectomy, so I would recommend a levonorgestrel intrauterine device for protection of her endometrial lining.
Okay, so Emily, be careful how you phrase that. She
Okay.
wanted to avoid hysterectomy. That's fair enough, and I get that, and so, but I'm going to ask you, but are you recommending the progesterone IUD because your real preference would have been hysterectomy? This is your backup choice given what the patient, her preference, or is this what you would have recommended, all things being equal? If you,
I think all things being equal, I sort of tend on the side of IUD. For this patient in particular, like I said, she has a lot of medical comorbidities. And so being conservative, I would probably recommend a IUD and then refer her to GYN oncology for further management, which in the end is what happened after I stopped, after I submitted my case list.
So what did the oncologist say?
So upon referral, she had imaging. She presented to the ER about 2 weeks post her hysteroscopy. They found a 9 centimeter right adnexal mass, and then a left adnexal mass that measured 10 centimeters. And that was even with the GYN oncology in place already. So when she presented to them, they had additional imaging, and she underwent hysterectomy and bilateral salpingo-oophorectomy.
Did she end up having cancer?
She did not, thankfully.
Okay. All right. So let's talk about this. It's interesting. I had a patient very similar to this, but she was a postmenopausal patient. This was before we were doing endometrial thicknesses, and she was a nun. And I did an endometrial biopsy, and it came back, I think it was like focal complex atypical hyperplasia. And I told her she needed a D&C hysteroscopy, which we did. And it came back, completely benign, and the endometrium looked as atrophic as I could possibly imagine it would look. And I said to her, "Look, you've got this on the biopsy. I've got to assume that's what's there." So I recommended a hysterectomy. And doggone if she didn't actually have grade 1, stage 1, but she had endometrial cancer. I always teased her that it was divine intervention that saved her. not me either. but her. Yeah. So, it's kind of like you got to assume the worst of the two results, when you're managing the patient. So again, this is inconclusive for us, so it's a little bit different. And obviously the patient didn't want a hysterectomy, but as you said, given her risk factors, progesterone IUD would have been great for her. Again, honestly though, if this had come back showing complex atypical hyperplasia and the patient was finished with childbearing, I would have absolutely recommended a hysterectomy, even if the hysteroscopy polypectomy was D&C was benign.
And that was our discussion. And I practice in a very rural community that I grew up in, and so I know my patients on the outside of the hospital system as well as the inside. And so my discussion with her the whole time was given your risk factors, you are most likely, even with the plain biopsy result, you're most likely going to have to at least see GYN oncology, just because her risk factors were very high. So,
right.
Thankfully, she didn't have
Okay.
cancer.
Yeah, thanks. What were those 2 ovarian masses?
They just, on ultrasound as well as CT scan, they almost looked like a peritoneal sort of peritoneal. And so on her pathology, it just said benign adnexal cyst. So I don't think it was just peritubal. I think it was ovarian. But I saw her at the Mexican restaurant 4 days ago, so she's doing great.
Well, next time you see her at the Mexican restaurant, slip her a little bit of estrogen because she's only 41.
Yeah, she's getting some. Don't worry.
Good deal. Hey, thanks, Emily. That's kind of an interesting case.
Yes, sir. Thank you.
All right, so let's take the comments and questions that came in. So Elizabeth, thank you for sharing. Hypothyroidism is a risk for preeclampsia and placental abruption. Thank you for triggering my memory. Definitely on the preeclampsia, rings a bell, and the abruption. Obviously, I'm taking your word for it. Thank you very much. That sounds familiar too, but the preeclampsia, I especially appreciate that because that's true. We go over thyroid storm management. Okay, so again, the key thing here with thyroid storm, and if you don't have a patient that actually had thyroid storm on your list, but you have, let's say, thyroid disease, either hypo or hyper, you should be prepared at a high level to talk about thyroid storm. So our other Emily told us at that time that she was going to involve ICU and MFM, and we kind of went over that. I think that's really great. The medications that we would prescribe would be PTU. We would also prescribe iodine replacement, and that can be given in the form of 10 drops of Lugol solution, as Emily told us. We would give a beta blocker. These folks usually are very agitated, they're tachycardic. So the real purpose of the beta blocker is to try to bring down the heart rate, make them a little more comfortable. And then the last thing is the intravenous steroids. And the purpose of the steroids, again, is to prevent peripheral conversion of T4 to T3. So again, trying to get a hold on the excess thyroid hormones. So hopefully that answers your question. Then the next comment came in about this last case. Wouldn't we want to do a hysterectomy given her obesity? So again, certainly the obesity with a BMI of 41 is definitely a risk factor. As we discussed, I'd be concerned about this patient given the original finding. If they're inconclusive about it, it's a little tricky, and especially if the patient doesn't want a hysterectomy. I mean, the bottom line is even if she had frank cancer and she doesn't want a hysterectomy, obviously we can't do it. The progesterone IUD, if she did in fact have complex atypical hyperplasia, will reverse that hyperplasia in over 90% of instances. The problem is when that IUD comes out, there's a over 90%, especially in obese patients, relapse rate. So that would be the concern with the progesterone IUD. And again, if we knew for a fact she had complex atypical hyperplasia on either of these 2 specimens, the recommendation would be to do the hysterectomy. Again, unless she wants to preserve fertility, in which case the progesterone IUD would be the next best option. Okay, that's it for our questions. I'm going to put everybody's hand down that has their hand up now, and I'll ask you now that we have everyone's hand down, if somebody has a question or comment that they want to make verbally, please do raise your hand at this point. Looking one more time, scrolling through here. Okay, I don't see any hands up, nor do I see any other questions in the box. So I will look forward to speaking to you guys Wednesday. We'll be doing structured cases. Thank everyone for their participation tonight, for volunteering, and also for our experts weighing in, and our folks fact-checking and adding stuff in the question box. So thank you. And we'll speak to you on Wednesday. There will, of course, be another webinar tomorrow night. Have a great evening and happy Halloween.